most frequently missing in doing this prediction? And then another question will be about the use of data from earlier patients that you have mentioned. So the first, what kind of information or data you're most frequently missing in doing this model of prediction?
Yeah. So what is a clear trend in the missing data is that so over time, mostly so patients after they receive the treatment, they receive a follow-up at fixed time point. So for example, at a few weeks after the therapy, but also at 6 months, 12 months, and different time points after the treatment. And then what you see is that as time progresses, there's more patients who drop out, and sometimes, yeah, the reasons are known, but sometimes it's not known. So that's the most. It's mostly in whether patients had long-term complications or not, and then as time progresses, there's more missing data. It's usually at baseline the data is quite complete. So at the moment of that patients enter or start the therapy, then usually everything is there. So you know the treatment plan, but you don't know if patients had complications a long time after the treatment.
Okay, so does that mean that are mainly long-term data that are missing because of the low rate of survival, for example?
Yeah, exactly. Yeah.
Okay.
And do you know what drives the decision to prescribe either one or the other treatment? Or is there a risk that, for example, doctors would prescribe proton therapy in patients who seem to have a more advanced tumor, or the opposite, which could also impact the results?
Yeah, currently the data used for developing the model is based on not on people who receive proton therapy, but standard radiotherapy, if I'm correct. And so there you don't have that decision that influences the data yet.
Okay.
But we are currently also there. So it is currently, this selective procedure has been used for a while now. So for, I think, 1 or 2 years maybe. And so the first data is also coming in now, and in Groningen, and also we are currently looking at if this has if the models are still reliable in when you change the way you assign treatment.
Mm-hmm. So for the moment you cannot, so how will the comparison then be made? All who had radiation therapy versus all who had proton therapy, but with matched patients or matched tumors, or?
Yeah, so what we'll, one way to how we now evaluate, for example, the prediction models is that, or one way to do that would be to check if the model, so the model predicts a risk for a certain patient, and then it has been a while now since, so if for 6 months actually, for if a patient has, for example, swallowing problems after 6 months, and then you can check for those patients if they actually experienced swallowing problems at 6 months after their therapy, and that is matched against each or compared with each other. And then for the two groups, you can see how well these predictions are. So that's, but yeah, so this is a bit simplified, but this is that is how the evaluation is done, I think.
Okay.
Just to add to that, we're looking into ways how to compare basically the effectiveness or the ability to reduce toxicities in photons and protons, to compare those two treatments. The difficulty is that, I mean, you select patients based on their risk of complications, and those with the highest risk of complications will receive proton therapy, and those with lower risk will receive photon therapy, because then there's less to gain from proton therapy. So a direct comparison between the two groups who receive proton therapy and photon therapy will be confounded, basically, because those two groups are not comparable in terms of baseline risk and baseline prognosis. So we're now looking into methods on how to compare those two treatments head to head, basically. But this is still in progress. And as Tuur said, in clinical practice now, as how the indication protocol is used, or how the prediction models are used, is that two plans are made, so with protons, one for protons, one with photons, and there's a certain threshold defined based on the type of toxicity. So the worse the toxicity is, the lower the threshold is to qualify for proton therapy. That's how it currently is implemented. Which is a small addition. Wasn't sure whether that was clear, but
no, it's clear.
And currently, all these data are from the Netherlands. That's probably something that's of interest to HTX as well. So most data are now from the Netherlands, but it will be nice within the context of HTX to also test how well the models perform actually in populations outside of the Netherlands, so from other countries, and see whether these models can actually be used in those countries as well, especially if they also have the possibility to refer patients to a proton therapy facility, or maybe even across borders. I don't know whether that's possible or how that would actually work. That's not my expertise, but it could be of interest as well, or at least testing the models in outside of the Netherlands is also something we're interested in.
When we had the HTX meeting in Bern, I think we discussed with EURORDIS on which other centers could be contacted and could participate. So of course, in between we had COVID, but do you know if some progress were made there to get access to other medical files? Or?
Yeah, so EURORDIS is also involved in this case study, as you know, and as Tuur also mentioned, and they have a big network across Europe, obviously. I think they have made contact with, I don't know by head, but I think with several countries who are at least interested, or from which EURORDIS are pursuing to collect data. I think one of the countries, I think was Italy, I think the UK was mentioned as well. So there are initiatives ongoing to get those data, to get data from other countries as well. And indeed, as you said, COVID has made things easier over the past year, also in terms of data sharing. But that's being worked on. So, I mean, with all the legislation in terms of data protection and all those kind of things, I mean, data sharing is difficult, but progress has been made. So I hope, I don't know, at the end of this year, next year, we'll be able to get access to data from other countries as well.
And do you have any plans? So here you work mostly with retrospective analysis of files and images that you had, but any plan to collect prospectively this information, or because one thing that probably you don't have is from the patients their own assessment of the quality of life or impact of the technology on their tumor or their health. Is this something planned during HTX to collect patient data, patient experience with these different technologies, or not?
Tuur, do you want to answer the question?
Yeah, so yeah, currently the data collection in Groningen is prospective in the sense that it has been upfront. They are upfront been organized to question, or to ask these complication questions, and they use structured surveys from the EURORDIS about, I think, also quality of life and head and neck cancer complications. So it is quite structured data collection.
Okay.
Yeah, I think it also includes both physician-rated and patient-rated quality of life questionnaires, indeed, from the EURORDIS. Yeah, and there is a bigger data collection ongoing or started. Not sure whether it started, but it's called ProTrade. So it's prospective data collection, basically for proton therapy, but ideally also for other centers using more traditional radiotherapy to collect data on basically patients undergoing radiotherapy. I think the data collection has been standardized and also includes quality of life questionnaires, for example. And I think there were also initiatives to extend this beyond the Netherlands. So ProTrade is a Dutch initiative, but also the EPTN, the European Proton Therapy Network, has also been, I know they're also interested in a more prospective data collection, which is based on the whole ProTrade data structure. So the idea is that in the end, we have a sort of, as we call it, sort of learning healthcare system. So we have these models that select patients. We have a prospective data collection that continually accumulates data from these patients that are treated with either photon and proton therapy, and that using those data we'll be able to sort of more or less continuously or periodically at least update these models to make sure that the choices the models make or indicate between photon therapy and proton therapy are as up to date as possible and as accurate as possible.
Okay, maybe it goes beyond your research here, but I presume that proton therapy in general is used for very severe cancers. I know it's difficult to compare different tumors, but if the case, then one question could be, when a technology, the capacity of the technology, the offer is limited, often they look at the survival after the use of the technology. For example, in organ transplant, people who have a short life expectancy to begin with typically are not selected to receive an organ transplant, and they reserve it to those who might live longer. So in that case, to prioritize which patients would benefit from proton therapy, one other important information would be what is the average survival after proton therapy compared to other tumors. I know it's a difficult prioritization rule, but I think in practice that's more or less what is applied. And the impact on the complications is one thing. The direct benefit for the patients is one thing, but decision makers might decide based on other information. So is this something you can measure as well? Maybe an increased life expectancy if the treatment is not only more effective to reduce the risk of complications, but maybe more effective to treat the tumor and to prolong life as another benefit? Or
yeah,
shall I answer this question? Yeah. Yeah, so as I indicated, the initial use, I think, as far as I know, I mean, I'm not a clinician nor a radiotherapist, but is that basically the tumor control is the same with photon therapy and proton therapy. That's the initial take, and that the main advantage of the proton therapy is that there's reduced radiation to the tissues surrounding the tumor. And as a result, there are less, say, side effects or complications from the radiotherapy. I think there are studies or maybe indications, types of tumor where they are using or experimenting with increased dose with proton therapy, because you are able to better target the tumor. It's potentially easier to confine the radiation to the tumor, so you do less damage to the surrounding tissues. So basically you can crank up the radiation to the tumor. But so then it becomes more of a, let's say, effectiveness question. So indeed tumor control then comes into play, while we mainly focus on side effects, on the reduction of toxicities. But I don't know the actual status from those studies or those therapies. I know there are different types of cancer that are, I think, sometimes don't qualify for proton therapy, while others qualify, other types of patients do qualify for proton therapy even without having to show a benefit from proton therapy in comparison to photon therapy. I think brain tumors, for example, are one example. And also I think in children, proton therapy is advised above photon therapy because you don't want to damage any of the tissues surrounding the tumor in children or in the brain. There are several types of cancers that in which the strategy that Tuur presented is applied. So head and neck tumors is one, breast cancer is one, the esophagus is also as they call a model-based indication. So yeah, it depends a bit on the type of tumor, what the exact strategy is in terms of whether you can actually qualify for proton therapy, and if you qualify, how you should qualify. Is it based on a risk, on a modeled risk, as Tuur showed, or is it just simply by indication that you already qualify for for proton therapy? So there is a distinction between different cancer types. And something else to mention that might also be important is that the models that are used, or the let's say model-based selection, the protocols that are drafted from these are all indication protocols. So that means there is an indication if a patient qualifies, so if there is an expected benefit for proton therapy, they can qualify for proton therapy, but that doesn't mean they actually need to get proton therapy. So this is just a prerequisite to qualify for proton therapy and to get it reimbursed. But it's always a, let's say, a discussion with the patient, with the clinician. I mean, if a patient is indeed, as you mentioned, is really sick and they have to travel over 100 kilometers, let's say daily, or they have to stay in a hotel or a facility close to the proton therapy facility, that might be something either the patient or the clinician thinks is not really, let's say, feasible. In that case, they might decide not to go for proton therapy, although they would qualify for it. So in a way, the prognosis does play a role in the clinical decision making, but not directly in the models as we use them, because we mainly focus on the toxicity, so the side effects on treatment, rather than the actual effects on survival. Quite a long story, but I hope that's clear.
It's very interesting. Yeah.
So in fact, the results will be more used to convince healthcare providers to invest more in proton therapy facilities, more than to indicate, more than to say, to conclude that patients with head and neck cancers should be prioritized as opposed to other cancer patients for this kind of treatment. Because it's an important benefit for people with head and neck cancer to benefit from proton therapy, then more of them maybe could become eligible or should become eligible for that treatment. But if the capacity is limited, that would be to the detriment maybe of other patients. Yeah. So the best possible use of the results, if positive, of course, would be more to convince the decision makers and the payers to invest more in proton therapy to better serve the needs of the various cancer patients.
Right. I think if the results show that proton therapy is beneficial to all those that were selected for the therapy, let's say in the most extreme case, it might be interesting to invest in additional facilities to see whether also the, let's say, lower risk or the patients that potentially have a lower benefit from proton therapy but might still have a benefit can also be given proton therapy, and to check whether also those patients would actually benefit from the therapy. So yeah, definitely, this is probably a first step. Indeed, I think in other countries there are way more proton therapy facilities than the Netherlands. I think the US has way more, for example, than the Netherlands. So that's much more possible in that sense.